So now contraception in females with history of venous thromboembolism as well as menorrhagia. Remember that for patient with the history of venous thromboembolism, COCP, or UKMEC4, and the progesterone only drugs such as POP, progesterone only pills, Nexplanin, and IUS or Mirena, they are UKMEC2. The only UKMEC1 drug for a patient with a history of venous thromboembolism is IUD or intrauterine copper device, IUCD. So again, patient with history of venous thromboembolism, COCP, UKMEC4, and all the other contraceptive methods such as POP, implants, and Mirena, they are UKMEC2. The only UKMEC1 drug for patient with a history of venous thromboembolism is intrauterine copper device. While on the other hand, for menorrhagia, IUS is UKMEC1 and IUD is UKMEC2. So what will happen if the patient present to us with both of these, with the history of venous thromboembolism as well as menorrhagia? What will we do? The thing that we do will be
IUS.
Yes, IUS, because it still can be used because it's a UKMEC2 category drug for patient with menorrhagia. For patient with a history of venous thromboembolism, IUS is UKMEC2. So if a person present to us with personal history of venous thromboembolism plus no menorrhagia, it means no contraindication to use intrauterine copper device. The best option in this case is a UKMEC1 drug, that is IUCD, because the person is having personal history of venous thromboembolism. Now the person with a personal history of venous thromboembolism plus she is having menorrhagia. Now we also want to manage menorrhagia, and we use IUCD because it is UKMEC1 in VTE, but it will worsen the symptoms of menorrhagia. So we will opt for IUS because it will improve menorrhagia as well as it can be used in a person with a personal history of VTE because the benefits outweighs the risk because it is a UKMEC2 in VTE, so it's safe to use it in such condition. So personal history of VTE with no menorrhagia, intrauterine copper device, personal history of VTE with menorrhagia, IUS is our choice. Personal history of VTE plus menorrhagia, and the person is looking for a short-term contraception, then we will go for other progesterone only drugs such as POP, progesterone only pills. Then we will use progesterone only pills if the patient is looking for a short-term contraception. So some contraindication for the use of COCP: if the patient age is above 35 and she is a smoker, then COCP is UKMEC3 or 4. If BMI is above 35, COCP is UKMEC3. So it cannot be used in smokers, in female who are obese, in female who has a history of hypertension. Even if it's adequately controlled, it's still a UKMEC3 for the use of COCP. history of venous thromboembolism, UKMAC4, history of migraine with aura, UKMAC4, migraine without aura, UKMAC3. So migraine with aura or without aura, COCP cannot be used. Now, another scenario, contraceptive for the patient with migraine with aura. So which drugs cannot be used in patient with migraine with aura? They are COCPs, absolutely contraindicated. And the drugs that are okay to use are POP, IUS, IUCD, depot, medroxyprogesterone acetate, progesterone only implants. All of them can be used in patient with migraine with aura, except COCP. They cannot be used. The best choice among these is IUCD, intrauterine copper device. For patient with migraine with aura, IUCD is the best one. POP, IUS, and medroxyprogesterone acetate and POP implants. You can say they are the second line. So an 18-year-old with some learning difficulties using condoms and want an alternative contraception method. So she is having learning difficulties. So oral contraceptive pills are not a good option. Again, some contraindication: smoking, obesity, BMI more than 30 kg per meter square, history of thromboembolism, learning difficulties, migraine with aura, hypertension, even if it's well controlled, contraceptive methods in someone wanting to conceive soon, a woman who wants contraception but would like to stop contraception in 6 months because she would like to try for a baby, then we cannot use IUS, IUCD, and implants because would be waste since most of these last for a few years and they take one NHS appointment to insert and another to remove. So if a woman wants to get pregnant after 6 months, she is looking for a short-term contraception, IUS, IUCD, and implants. They should not be used. And with Depo-Provera, though it's a short-term contraception, fertility can take up to 8 to 10 months to resume from stopping Depo-Provera injection. So that's why Depo-Provera can also be not used. Okay to use in short-term contraception has only POP and COCP. Contraception and Pearl Index. Pearl Index is what is Pearl Index? Pearl Index is the number of pregnancies that occur in 100 women over 1 year of contraception use. What is the most effective contraceptive method? The most effective is this, you can see from this table that male sterilization or subdermal implant. The most effective is subdermal implant. It has a Pearl Index of 0.05. So if 100 women are using subdermal implant, the chances of pregnancy is 0.05, which is almost zero. So this is the most effective. The second number one is male sterilization, that is 0.1. On the third is Mirena or IUS, 0.2. And on the fourth is female sterilization, that is 0.5. And then is copper IUD. So you can see that Mirena or IUS is better than female sterilization. So remember these Pearl indexes for the most effective one. Mirena, female sterilization, male sterilization, because in the exam, sometimes in the options, they will be given and you will be asked to select the best one, the best method of contraception. So you need to remember these values to select a correct answer. Only 4 or 5 options will be given and you will be
So
asked to select the
if
best
there are
one.
100 women who use subdermal implant, so there will be only 5 women they will get pregnant, because I
Not
remember
5,
we had a question
0.05,
like
0.05.
0.05 means like out of 100 how many?
0.05 means like if 500 women are taking then there is a chance of one pregnancy.
One
Out of
pregnancy.
100, out of 100 means 0.5 means there are very less chances.
Right.
So for 200 it will be 0.1. For 300 it will be 0.15. For 400 it will be, and so on. So for like 1,000 pregnancies, there will be one pregnancy. If 1,000 women are using, then there is a chance of one woman to get pregnant. So that's why subdermal implant are the most effective methods, followed by male sterilization, and then Mirena, and then female sterilization, and then copper IUD. Progesterone only injectables, you can see that they have a Pearl index of 0.2. Progesterone only pills 0.3. Combined oral contraceptive pill, they are also 0.3.
Okay.
See, 0.5% means the risk of a female getting pregnant is 1 in 200. And 0.05 means 1 in 1,000.
1 in 1,000.
Almost.
Yeah.
The contraceptive method with the lowest failure rate is Mirena, 0.2%, even better than laparoscopic tubal ligation. So this was a question that was asked in the previous exams, and in the options, five drugs were given. In those drugs, IUS had the lowest failure rate, because for IUS it's 0.2%. The lowest failure rate for subdermal implant and male sterilization are even better than Mirena or IUS. One other point that you need to remember about contraception is that no contraceptive method increases the absolute risk of ectopic pregnancy, but it increases the relative risk of ectopic pregnancy. Just remember this point, that contraceptive method does not increases the absolute risk, but it increases the relative risk of pregnancy. What does it mean? It means if a patient on IUS and IUD gets pregnant, there are 0.2% chances, 1 in 200 chances that the patient will get pregnant with IUS or IUD. But still, if she gets pregnant, then the risk of ectopic pregnancy will increase. So relative risk is increased with IUS and IUD, but absolute risk is not increased. Absolute risk is the individual risk of a woman, and relative risk is the risk of a woman compared to the other women who are not taking IUS or IUD. So now some problems with contraceptive method. Sometimes female may get vaginal spotting after initiating hormonal contraception such as COCP. So if a female gets vaginal spotting after initiating COCP and it's within the first 3 months, then you will reassure the patient. And if it continues for more than 3 months, the vaginal spotting is still happening, then you can consider shifting to another contraceptive method. So the problem with COCP is that the female can develop vaginal spotting. So if the vaginal spotting is within the first 3 months, then you will reassure. And if continue after more than 3 months, then you will consider shifting to another contraceptive method. Now, a problem with the intrauterine devices is that they can be lost or missed. So they are lost, and on speculum examination, you cannot see the device thread. Then you will perform and they ask you about the next best step in the management of such patient, then you will perform an transvaginal ultrasound. So on speculum examination, you are not able to locate the device thread. The next step is transvaginal ultrasound. If still you cannot see the thread, then you will go for abdominal X-ray. So a female present to you with loss of intrauterine device, and on speculum examination you cannot see the thread. The next option for the management is transvaginal ultrasound, and if still cannot locate the IUD, then abdominal X-ray. Now, some side effect of Depo-Provera, like COCP with Depo-Provera, females can develop vaginal spotting. Remember that the majority of the females who start Depo-Provera tend to have intermenstrual spotting. This usually settles down after a year of Depo-Provera use. So with COCP, the duration of vaginal spotting was 3 months. If it was more than 3 months, then we should consider to shifting to another contraceptive method. While with Depo-Provera, the vaginal spotting can occur up to 1 year. The vaginal spotting or the intermenstrual spotting, it will settle down in 1 year if a patient is using Depo-Provera. So if a female who is started on Depo-Provera comes to you with intermenstrual spotting, then you will reassure the patient and advise her to come back if these unscheduled bleeding becomes problematic. So the first option is to reassure her and ask her to come back if the unscheduled bleeding become problematic. And if she comes again and say that the bleeding has got worse or it has become problematic for her, it is affecting her daily routine, then you will start her on COCP for 3 months. Or mefenamic acid or tranexamic acid for 5 days. So if a female develops intermenstrual spotting with Depo-Provera, it's perfectly normal to get it, and the intermenstrual spotting usually resolve within 1 year. But if they become problematic, then you have 2 treatment options, either mefenamic acid or tranexamic acid for 5 days or COCP for 3 months while still on Depo-Provera. So you will continue with Depo-Provera, and along with Depo-Provera, you will prescribe COCP for 3 months or mefenamic acid or tranexamic acid for 5 days. And also, Depo-Provera injection can cause amenorrhea as well. So if a female present to you that she is not having any menstruation or any periods after Depo-Provera injection, then you will reassure her that it's normal to have amenorrhea with Depo-Provera. So combined oral contraceptive pills, they can be used in the treatment of menorrhagia or irregular menstruations. They can also be used in the patient with intermenstrual spotting who are on Depo-Provera. And a third indication for COCP are that they can be used to alleviate the symptoms of premenstrual syndrome as well. Now, a question to refresh our knowledge about COCPs or contraceptive methods. A 30-year-old woman complains of heavy irregular menstruation for the past few years. She has 3 children and has completed her family and is not planning for getting married again. Her past medical history include migraine with aura and pulmonary embolism. She undergoes pelvic ultrasound that reveals small submucosal fibroid and is anemic. What is the most appropriate management?
Endometrial ablation.
Endometrial ablation.
Mirena?
Is it Mirena? Yes,
Arena.
IUCD.
Yes, IUCD can be an option. So can anyone tell me a patient with menorrhagia and a history of migraine with aura? IUS is
COCP are contraindicated there.
UCP or UKMEC4. That's ruled out.
IUCD.
Arena?
IUCD.
Marina, IUCD, intrauterine copper device, she is having heavy irregular menstruation. So IUCD is also cannot be used because it's a UKMEC2.
Mirena.
For menorrhagia,
Then
is UKMEC2 for migraine.
The answer is Mirena.
Mirena is UKMEC2 for migraine.
uterine bleeding.
So the only option that we are left with, the best one of them is a uterine ablation. So this scenario is an example of when to choose IUS and when to choose uterine ablation. So this patient is having a history of migraine with aura. So migraine with aura COCP is UKMEC4. Mirena is UKMEC2. Depo-Provera is UKMEC2. And also she's completed her family and not planning to get married, get pregnant again. So Depo-Provera is not a good option as well because you need to take it after every 3 months. So the long-term option that we have is Mirena or IUCD or uterine ablation. IUCD cannot be a good option because the patient is having heavy menstruation. And IUCD or copper devices, they worsen the symptoms of menorrhagia. Now we are left with 2 options. One is Mirena and the other is uterine ablation. So Mirena is UKMEC2 in migraine with aura. There is still some risk, but it can be used if we don't have any other option. But in the option, uterine ablation is also given. So So considering the history of this patient that she is having heavy periods and her family is completed and she does not want to get pregnant again, between Mirena and uterine ablation, we should go for uterine ablation because the patient is having a history of migraine with aura. If migraine with aura history was not given, then Mirena was a good option.
Doc, you said for Mirena, migraine with aura is UCMEC 2. So
Yes.
meaning that the benefits outweigh the risk. So if the
Yes.
benefits outweigh the risk, why are we still not using it? Considering the fact that Mirena is UCMEC 2
There are some risks, but we have a better option, that is uterine ablation. You can say that uterine ablation is a UKMEC1 in a patient with migraine with aura and menorrhagia. Uterine ablation is not having any risk for migraine with aura.
So
So
what about
it-
the fibroids? She's got a small fibroid as well. So you trying that can be done like with fibroids, uterine ablation.
yes, that's also a good option. That's a good question. Let's read its explanation and we'll see which option is right. So this woman main complaint is irregular and heavy menstrual cycle due to fibroids, which has led to anemia. He does not want to get pregnant again. If this woman did not have a history of pulmonary embolism and migraine with aura, Mirena levonorgestrel releasing system would have been the best option as it can manage bleeding and shrink the small fibroids. Given that she has a history of pulmonary embolism and migraine with aura, COCP, Mirena, and Depo-Provera should be avoided because all of them are. COCP is UKMEC4, and the drugs that only contain progesterone, the contraceptive method that only contain progesterone, such as Mirena, Depo-Provera, they are UKMEC2. So if we can avoid these medication, then if we have some other option like uterine ablation, and we can avoid these contraceptive method, then it's best to avoid them. You can use them if you have no other option. So if you encounter such kind of scenario in the Plab 1 exam, in which a UKMEC1 and UKMEC2 drug both are given, then you will go for a UKMEC1 drug. If you can avoid the UKMEC2 drug, then you should avoid it, as in this scenario. So the copper IUD and uterine ablation, we were left with both of them. IUD worsen the menorrhagia, so it can also be not used because it's UKMEC2 for menorrhagia. It can be used if we have no other option, but as it worsens the symptoms of menorrhagia, or it is UKMEC2 for menorrhagia, so we'll avoid this one as well. Because IUCD won't address the heavy irregular cycles, so that's why uterine ablation is the best option in this scenario. So if we encounter the same exact scenario but without the history of pulmonary embolism or migraine with aura, then we will go for Mirena. Otherwise, if there's a history of migraine with aura and menorrhagia, then we'll go for uterine ablation. IUS, Depo-Provera, progesterone implants and POP are UKMAC2. So if the exact same scenario come in exam and uterine ablation option is not given in the options, then you can go for Mirena as well. Otherwise, if uterine ablation is given in the scenario, then you will select uterine ablation because Mirena is UKMAC2. There are still some risk associated with the use of UKMAC2 drugs. So if you can avoid UKMAC2 drugs, then you should avoid them. And as far as the small fibroids are concerned, endometrial ablation, Dr. Musa has asked that will they treat these fibroids? Yes, endometrial ablation can treat fibroids as well. So is this point and this scenario clear to everyone? Because there was a question exactly like this one in the November Plab 1 attempt. Is it clear, everyone?
Yes,
Dr.
Doc,
Abdullah?
it's clear. It's clear.
Okay. If somebody want to ask any question, yes.
There is another question. If, for example, the patient does not have this irregular and heavy menstrual bleeding, and she's just got this. If you scroll it up, the question, please. She just got the pulmonary embolism and migraine with aura with no heavy menstruation, and she has completed her family. So in that case, will we still pick uterine ablation, or
No, we won't pick uterine ablation in that scenario. If the patient is not having any irregular menstruation, she just only having a history of migraine with aura and or history of pulmonary embolism, and her family is completed, then tell me an example of a drug that is UKMAC1 for migraine with aura. The
so
only drug that is, yes.
the contraception which is used in that case would be copper device.
Yes, intrauterine copper device. You will select intrauterine copper device because uterine ablation, as I have told you before, is a procedure. It is done
Yes.
only if we don't have any other better option.
Right. Okay. Thank you.
IUCD is UKMAC1 for thromboembolism, for migraine with aura. So, but it is UKMAC2 for heavy menstruation.
Yes.
So if there is no history of heavy menstruation, then you can go for intrauterine copper device and not uterine ablation.
Okay. Thank you.
Somebody else has any question? So we are done with the contraception.